Veterans Administration to create a win-win situation through an important and challenging Six Sigma project. Please welcome the Executive Officer for the Department of Veterans Affairs, National Center for Patient Safety, Noel Eldridge.
Okay, just want to make sure I know how to advance my slides here. Thank you all for coming today, and before I forget, in case I forget at the end, I want to thank Susan Woods, a black belt that worked with us on this project, Jim Biesecker, and Michael McQuaid for their support throughout this project. Let me give you the acronyms at first, too. The ICUs here are the intensive care units. JCO is the Joint Commission on Accreditation of Healthcare Organizations. That's the group that tells people if their hospitals are good enough or not. And the VA is obviously the Department of Veterans Affairs. The Department of Veterans Affairs is the second largest federal agency. I don't think people generally realize this. Over 230,000 employees around the country, broken into three groups. The Veterans Health Administration that I work for, which provides health care to veterans. The Veterans Benefits Administration, which basically cuts checks and provides other benefits to people who served in the military. Cuts checks for those who are permanently disabled and suffered other problems based on serving in the military. And the National Cemetery Administration that provides burial services for veterans. So once you leave the military under the DOD, you'll get your health care from the VA if you're eligible, which most people are. And you get benefits, and then you're entitled to burial benefits as well. It's the largest health care system in the U.S. Most people don't know this either. We have over 150 hospitals around the country. We have a $25 billion budget. One thing that's different about the Veterans Health Care Administration compared to, say, Medicare and other federal agencies that provide health care is that we get a budget. The other agencies have an entitlement, different kind of entitlement than you guys are used to here. But Medicare costs what it costs. If you need to do more heart bypasses 1 year, and it just costs more money. If you need to pay for more drugs, it just costs more money. There's no budget. It's just you charge it up. We have a budget, and we're told to take care of every veteran that comes and needs care. So one thing that's good for us, the incentives align. If we save money on preventing hospital-acquired infections, which is what this project's about, that frees up more money for paying nurses, paying doctors, buying new equipment, et cetera. We don't have a disincentive to improve things. Other facilities sometimes may have no major incentive to save money, because if they get an infection, they just charge the insurance company for that infection. They have to just do it basically on the desire to do a good job. For us, the desire to do a good job lines up with also saving money. I'm going to go through two things, the background for this project and then the details of what we did with Susan and the rest of the 3M folks on the Six Sigma project. The CDC is the Centers for Disease Control. They're a non-regulatory agency. They're not like the Food and Drug Administration that can really tell people what they have to do. So they put out some guidelines in 2002 about the topic of hand hygiene, which encompasses cleaning your hands, wearing gloves, and doing other things to prevent microorganisms from being present on your hands when you're taking care of patients. Their guideline went out. It was interesting to people, me included, but there was no hammer behind it. There was no enforcement arm that went with it. In 2003, the Joint Commission made the CDC guidelines what they called a goal. And their goal is not really a goal, it's a requirement. And so transferring the goal, the guidelines into a goal made them requirements. And then all of a sudden everybody was freaking out to figure out what they had to do to meet this patient safety goal for 2004. These are the recommendations in the CDC guidelines. There's 44 of them in 8 different areas. So I wanted to present this because you might just think it's just, wash your hands, but it turns into a much more complicated process to unravel and to figure out what to do in response to. You can see there's different areas here. They involve using appropriate use of soap, appropriate use of alcohol hand rub, wearing gloves, wearing sterile gloves, what you do before surgery, what you do at the bedside, for patients that are not in surgery, what you do in doctor's offices, the supplies that you provide to people, the way you monitor things. There's a lot of recommendations that were turned into goals, which were turned into requirements. Just 1,350 words just of the recommendation. So why is this such a big deal? Well, hospital-acquired infections are the #1 complication or adverse event in healthcare. Preventing adverse events are what my office is set up to do, the Patient Safety Office. Adverse events are bad things that happen to people while they're receiving health care that have nothing to do with their underlying disease. So, for example, patients getting the wrong drug, patients getting wrong site surgery, patients falling in the hospital and breaking their hip when they weren't in there for a hip problem to begin with. A wide variety of adverse events that happen in healthcare that you've probably heard some about. Well, it turns out that hospital-acquired infections is really the #1 adverse event in terms of quantity and probably also in terms of severity, in terms of what happens to people when they happen. Most adverse drug events really aren't that bad. If you get the wrong drug once in a while, it's not what you want, but it's not really going to have a bad outcome. If you get the wrong microorganism put onto your wound after an infection, that can cause a very bad outcome, and it causes a number of deaths. The exact number is debatable, but the CDC speculates or extrapolates or estimates that it was about 20,000 to 100,000 a year. Quite often you see the number 88,000 mentioned, which is a lot. And the most common mode of transmission of these microorganisms is via hands. Some germs do pass through the air from one person to another, but most pass from one person to another by contact. And the most common mode of contact is from hand to hand or hand to some part of somebody's body or skin, or hand to an inanimate object like a vial or a syringe, something like that. The evidence contained in the CDC guidelines is very thorough. 423 references from decades of research on this topic, going back to the 1800s when it was first discovered that microorganisms were causing a lot of women's deaths in childbirth. That's where it all started, before they even fully understand the germ theory of disease. Bottom line here is there's a lot of evidence that goes to show these requirements, that these requirements are based on. I'm just going to highlight one particular paper. This is one that came out after the CDC guidelines, but it's a nice simple example. One hospital did a study where they changed from using soap to using alcohol hand rub. And in so doing, they reduced their hospital-acquired infections by 36% over a 16-month period. And one of the amazing things that came out of this particular study is they also tracked the cost, and that the average cost for a hospital-acquired infection was $4,800. 10 months of supplies was $1,600. So you can see the tremendous cost savings here, especially for an organization like the VA, because for us, $1,600 and $4,800, it all comes out of the same pot. For other organizations, it doesn't. They can charge back that infection to the insurance provider. We can't. We get a lump sum, and we need to take care of the patients with that. So if we can prevent a lot of infections by buying some extra supplies, it's a big improvement for us. And that's just on a financial basis, even if you didn't care about preventing suffering from the patients. Here's a couple of slides I'm going to show you on the CDC data. It shows, the slide here shows that the alcohol-based hand rub is just much more effective at killing germs than antimicrobial soap and regular soap. You'll see that the antimicrobial soap goes up to about 90% kill. The alcohol hand rub kills about 99% almost immediately. And the regular soap is really primarily for making your hands look good and smell good. It doesn't really kill a lot of microorganisms and feel good. This is one of the deceptive things. When your hands feel really clean after washing them with soap, they are clean on a macroscopic level. It doesn't mean that you've neutralized all the microorganisms that might have been on them previously. This chart actually, the plain soap line goes below 0, and that was brought to my attention by one of my colleagues, and I said, well, if you think about it, what that means is that at that point, after maybe 2.5 hours, you have more than you started with after washing your hands a couple hours later with regular soap. This is one that I think 3M has also shown with their product, that using the alcohol hand rub products as they're currently formulated is actually better for your hands than using soap, which might be unintuitive. because people think that alcohol is hard on your hands. But these products are about 62% alcohol, not entirely alcohol. The rest of the product has emollients and other ingredients to make them easier on your hands. So the alcohol hand rub products have really been shown to actually improve skin condition rather than harm your hands, which has always been a major impediment to increasing hand washing. Because when you tell people to wash with soap and water, they complain that their hands are going to get torn up. The first thing we did when we tried to address this project was to try to make it a little more manageable. We broke down the 44 recommendations in the CDC guidelines to 19 recommendations. That by combining recommendations and by eliminating ones that didn't have strong evidence. The CDC puts out guidelines with different levels of evidence. And the ones that didn't have the strongest level of evidence, we checked with the Joint Commission, the accreditation group, to see if they wanted to enforce those ones. They did not. So we could extract the ones that didn't have strong evidence and combine the other ones into just 4 categories. Now the next 4 slides I'm not going to go through. I'm just going to put them up just so that you have some healthy respect for what we had to do in this project. There's a lot of recommendations to deal with. So we weren't going to come up with a control plan that had 2 or 3 points or something, because there's a lot of recommendations. We broke them into ones that pertain to anybody who's going to touch patients. So this has to do with using soap, using alcohol, using gloves, going to the bathroom, things like that. This one is specifically for surgery. One of the things that came out of the CDC guidelines here was that it's not necessary to wash your hands for as long as surgeons typically do wash their hands before surgery. And it's not necessary to use this scrub brush to tear up your cuticles and such, which maybe was a badge of honor among surgeons that they really scrubbed good, but there wasn't any real data to show that that really is better at wiping out the microorganisms that might be present on your hands. The biggest thing probably that pertains to a company like yours is the supplies. And there's a lot of recommendations in there for supplies. The supplies that have to be provided to the healthcare workers. The alcohol hand rub, the antimicrobial soap, the pocket-sized alcohol hand rubs so people can carry it around with them. You can put them on a lanyard or a little belt clip, things like this to make it easy for people to use it. Don't refill soap, these kinds of things. The alcohol hand rub is actually 60% alcohol, like I said, so it's flammable. So there's requirements about storage. You can't just get a huge amount of it and just store it anywhere because it'll catch fire. Now, it'll burn like sterno. It won't burn like gasoline, so it's not an explosion hazard, but it is a flammable substance. And then there's recommendations for facility management, monitoring, things like that. Before I go into the Six Sigma part of the project, if you just remember one thing, the alcohol hand rubs are better than soap. And you say, why is that? One, they kill germs better. They kill microorganisms better. The one I called out here is norovirus. This is one that causes gastrointestinal infections that happen on a cruise ship. You hear that once, you've probably heard of that. That one is extremely hard to kill. You basically have to wash it down the drain. It's almost impossible to kill. Soap or alcohol hand rub doesn't kill it. But they're easier to use. Once you put the alcohol hand rub on your hands and rub it around, you've basically done the job. To use the soap, according to CDC guidelines, you have to turn on the water. You're not supposed to use hot water. You're supposed to use warm water. Wet your hands. Put the soap on your hands. Lather for 20 seconds. Then before you turn off the water, you take a paper towel, you dry your hands. You take that paper towel to turn off the water, and you turn off the paper towel. People are not going to do that every time. They're just not. And decades of research has shown that. With the alcohol hand rub, you just squirt it on your hand. Assuming you put enough on your hand, you can't help but do it right, because you're just going to rub it around all over your hand to get rid of it because it evaporates. So it's a much more effective thing in terms of being able to do it right. And then the history shows that soap is a loser. People only do it 20 to 50% of the time. It's kind of a losing battle to try to reemphasize and holler at people to tell them to use soap. This is where we started from. One of my colleagues in Arkansas that worked on this project put this chart together. 34 studies in the literature showed an average compliance of about 40%. And you can see there's one outlier there that goes at 80%. But in general, the question here is, when do people wash their hands when they're supposed to? When do they wear gloves when they're supposed to? All these kinds of things. It comes out to about 40% of the time. Every incident, every opportunity that's there, 40% of the time they do it. So that's the context. And here's the project that we did in response. This is, whoops, let me go back here. Just to remind you, ICUs, intensive care units, we focused on the ICU, and the CDC is the Centers for Disease Control, and JACO is the accreditation group. This is the chart that Susan put together on the project. What we're trying to do is improve the compliance to the CDC hand hygiene guidelines. Our baseline was 47%. We're trying to shoot for 85%. the physical limit is 100%, but we don't think that's ever going to happen anywhere just because of the realities of life. We started in October and we wrapped it up in May. This is a little timeline goes into a little more detail as to how this project started. It started at the highest level, not this particular project, but the idea of working together between 3M and the federal government. Your CEO, Mr. McNerney, visited Washington, D.C. and met with sort of our CEO, who was the Secretary of Veterans Affairs for the VA. And they talked about doing a project. That was kind of on the back burner for a while. I went to NPSF, is the National Patient Safety Foundation. This was a kind of a trade show or scientific meeting, and 3M had a booth there. And I talked to the 3M guy there, and they got my card, and they put it to Kim Reichling, who's the Washington rep. He contacted me about doing a follow-up because he knew that Mr. McNerney wanted to do something with the federal agency. And we started talking about it over several months. And by September, we had worked it out to do a project on the hand hygiene. We got the training in October and November. Sheila Stewart did an excellent job with that, and the other folks involved. We had 6 people get training. And then from October through May, we had basically weekly teleconferences with Susan. And we used the WebEx, the Global Crossing System, to talk about and go through all the tools on the screen with Susan operating the computer and us talking on the phone to go through everything. Our team had 3 doctors, 7 people trained as nurses in various roles now. I'm an engineer by background, a biomedical engineer by background, and Susan has a chemistry background. We had an epidemiologist as well. So we had a wide-ranging group in terms of backgrounds, and commitment was consistent, though. Everybody wanted to do this project and wanted to have a good result. These were volunteers. We kind of talked around, and we got 3 hospitals that really wanted to work with us on this project. So we didn't have conscripts. Everybody here was somebody who really wanted to make progress on this. The Des Moines VA, the Minneapolis VA, and the Fayetteville, Arkansas VA. This is the funnel that everybody's got. We went through all these steps. We had 59 inputs at the beginning. We had 6 inputs to the FEMA, and I'm going to cut to the chase here into some of the other features. What do we measure? This is one of the things, figure out what to measure. We would like to have measured hospital-acquired infections, but we didn't have the ability to do that because they're not measured consistently across the VA right now. And they're measured in different ways at different places. And actually, this project brought some light onto that topic, and there's actually a working group that's been set up to fix that I'm on, that's being led by the infection control people and the public health people. But we couldn't measure hospital-acquired infections, so we had to measure process. The process we're measuring is the staff compliance. Basically, you watch people what they're doing, and you see if they do what they're supposed to do in terms of hand hygiene when the opportunity arises. We have a whole series of 8 or 10 questions that we used. We had a clipboard checklist, and people just kind of hung around the ICUs and watched people. There were people that worked in the ICUs that did this, so they weren't obvious spies. That was one of the things that we talked about, that the infection control people, if they went to the ICU, it would be clear that they were in there for some peculiar reason. Why are you hanging around here? So we had actually nurses that work in those ICUs, do the job while they were doing their regular job. The other thing we measured was the volume of the product used. The volume of alcohol hand rub used, so that we'd be measuring the same thing 2 different ways. The third thing we measured was the staff attitudes and perception of compliance. We wanted to know what people thought they were doing, in addition to what we thought they were doing. One thing we saw was that people were not using antimicrobial soap throughout the VA, and we realized this had to be changed. They were using regular soap in some hospitals. So instead of just working in these 3 ICUs, or these 3 hospitals, 4 ICUs, we checked across the board to see how many people are using antimicrobial soap, and we put out a guidance to tell them to start using antimicrobial soap in patient care areas. The last 2 are making sure that nobody's wearing artificial nails. Artificial nails provide a habitat for microorganisms to live in between the nail and the artificial nail. It's been associated with deaths in neonatal intensive care units where infections have come from nurses' fingernails to premature infants, and also in some other settings have caused some very bad outcomes. We had one with 4 bloodstream infections in one day at one hospital in dialysis patients based on microorganisms going from artificial nails to a vial that somebody put a syringe in, pulled out the product, but also pulled out the germs and injected it into people. So artificial nails are a no-no. And then everybody's shifting on that one. So one thing that we did here was we focused on what was in the CDC guidelines. Like some people said, well, what about rings? Okay, what about rings like this? The CDC guidelines said that there was soft evidence for getting rid of rings. So we said, no, we're not going to get into the rings. We used the CDC guidelines basically like a Bible. If it said you do it, you had to do it. If it didn't say you had to do it, you didn't have to do it, because we didn't want to get into arguments over each point at each place. And then as a counterbalance, we wanted to check staff satisfaction with these practices, so that as we made everything better in practice, we weren't making everybody frustrated and angry about it. And this is one of the first things we saw. Susan put this together pretty quick. It was great. This is what people think they're doing. This is what was measured with the observation. So we realized early that people weren't intentionally ignoring the rules. They thought they were doing the right thing. Four kind of themes came out of our cause and effect in FEMA. The access to the product was a big one. Getting rid of any good excuse for not doing it. If the product's not there, you kind of have a good excuse not to use it. Patient empowerment, this is an elusive one. The idea here is to try to get the patients involved, to ask the providers, have high expectations about hand hygiene in their healthcare workers. This is one that's been identified by many people, but is hard to make progress on. The third one is get staff aware of the requirements. This is not a whole huge education program. There isn't that much to educate people about. They generally know what they're supposed to do, but they may not know exactly what they're supposed to do. So you need to do some education, some training, but it's not a whole huge education effort. You need to know that you need to wash your hands, for example, before and after touching a patient, not just after. You need to know that you need to wear sterile gloves for certain things. You need to know that you need to wear regular gloves if you're handling dirty linen, things like that. Some basic things that need to get transmitted to people. And then we need to work on the culture, which is basically the way things are done in any place. There's a certain informal norm that develops. What's accepted as standard practice. It's basically a standard practice for people not to follow the rules as far as hand hygiene goes. So you want people to have high expectations for their subordinates. You want people to have high expectations for their peers and for themselves, and to sort of change that culture as to what people expect as the standard behavior. This is the data we have, and it's terrific. This is the initial capability and the final capability at the 4 intensive care units. Overall, we went from 47% beforehand based on the watcher data, and we went to 80% afterwards based on watcher data. And these were done in 3 different hospitals in 4 different units. The MICU is a medical intensive care unit. The SICU is the surgical intensive care unit. This is from Minneapolis, which has a large hospital. The other 2 hospitals are smaller and just have 1 intensive care unit. And these were done using the same checklist, but by different people, different times a day. So the data, the consistency is really, really pretty astounding. It came out almost identical across the board at the 4 places. This is another way of kind of making sure that we weren't kidding ourselves. The watching data is kind of a snapshot. It depends on when people were there. Although we did have 2,300 observations before and 1,700 observations afterwards, that's still like a series of snapshots. This is kind of like time-lapse photography. This is a month-by-month version that shows that even when you're not looking, the practices were changing. This is the usage of the alcohol hand rub product before and after at one particular hospital. And across the board at the three hospitals, intensive care units, it approximately doubled before to after the use of the alcohol hand rub product. Slightly less than double, something like a 90% increase. Here's some summary data. I've already gone over the first 2 points. The antimicrobial soap was another one. We noticed beforehand that only 80% of the hospitals had antimicrobial soap somewhere in the hospital beforehand. We got that up to 98%, just by telling people about it and telling them that they had to get rid of the non-antimicrobial soap. This was not really part of Six Sigma, it's just part of getting the word out. And we went from 44% of the hospitals using only antimicrobial soap to 81% of the hospitals using just only antimicrobial soap when they use soap. We saw that the staff were not wearing artificial fingernails in the intensive care unit, so that's not a problem. And then we showed in the counterbalance that satisfaction actually slightly increased over time rather than decreasing. So this is a win because we weren't trying to show a major increase here. We're just trying to make sure this didn't drop off the map, that didn't go from a decent level of satisfaction to a really poor level of satisfaction. So going into the control plan, we have a lot of items in this control plan, and I've adapted our control plan to kind of fit on the screen here. There's obviously the same number of columns as everybody else has, but I threw in a column here about the follow-up workload. And the ones that actually require some work in the long term I've highlighted in red. Most of them are one-time fixes, like getting antimicrobial soap in the hospital. That's a one-time fix. Unless there's somebody tries to undermine it, once you get used to buying that product, you just keep buying it. On this particular part of the control plan with regard to the product, the requirement here is for monthly tracking of the use of products. So basically, how many cans do you use, how many bottles do you use of this alcohol hand rub? And then you've got to cross-reference that to the patient days of care in the ICU so that you can turn it into a rate. The dosage, the number of doses per patient days, or per 100 patient days, which was what was on that chart before. This one is basically the behaviors. This is going to be monitored annually with the watcher data. So once a year, we're going to go back and do that watcher data that we described before. Now, we've tied it into this one, this previous one. If the monthly tracking data drops down out of control, then the guidance is to go back and do the watcher. So that if you start dropping down, go back and see if there's something going on there that would be correlated by the watcher data. So it's a kind of a complicated one, but that's the way we set it up. There's a lot of things about awareness. Almost all of them are easy. Putting some posters up. We developed a series of posters. Updating the training. The infection control staff at the hospital does an annual training. We want to make sure that it's up to date because they could just be using the one they've been using for 5 years. So across the board, everybody has to go to this focus of using the alcohol hand rub over soap and the other things that are in the CDC guidelines rather than just what was their personal opinion as to what was important about hand hygiene. Several other things here. We're trying to get the families and patients involved as well. So, for example, in the waiting areas, we're putting up posters, we're putting up brochures in the waiting areas so that people understand what their expectations are. One of the most important things to train in this aspect is for people to understand that the alcohol hand rub is better than soap, because patients and visitors might think that it's a shortcut or inadequate or inferior method for hand antisepsis than soap. If you see your practitioner, your hospital worker, your doctor, your nurse using alcohol hand rub, if you didn't know better, you might think that that's kind of cheaping out on it. They should be washing their hands with soap. So we're communicating to the patients and the visitors that this is really a much better way to kill the germs on your hands. So that's one important thing to get across. We've developed a series of posters. We developed about 20 of these posters, and they tied into to some other efforts we were doing in another part of the VA. It was a nice synergy. We went in with the public health office, and we're actually going to we developed about 20 posters that are designed to be rotated out, and they're going to be going to a package that'll be shrink wrapped, and there's going to be 50,000 copies made of this package. So there's going to be like 1 million of our posters printed, which is quite astounding. So I can send Susan as many as she wants. And I did the one on the left. She did the one on the right. Okay. There's some other ones we developed in here. We're trying to see that some of these things were based on the things that we saw in the FMEA, things that were misperceptions, like why don't people wash their hands or use alcohol hand rub? Because they feel their hands are clean. They're not conspicuously dirty. So we want to drive across the point that, you can have microorganisms all over your hands even if they look and feel clean. And then we've developed a poster that tells the patients and the visitors in a very conspicuous way it's okay to ask about it. And we've communicated that to the providers that they should respond appropriately if somebody asks them about washing their hands. We've actually developed this poster in another version that has more contrast for people with low vision. It's got a dark background and a bright one. And we've also put this one, the patient and visitors poster, in Spanish too. All the veterans can speak English because it's the language of the U.S. military, but the visitors quite often can only speak Spanish. And this is the last part of the control plan, policy. You have to have the policy in place in a big bureaucracy, but it's not the key thing. The policy mostly helps people that want to do the right thing, because then they can, if somebody gives them a hassle about doing the right thing, they can fall back on the policy and say, hey, I'm not just making this up, it's national policy. So we've done that. We put out some guidance in December, and we're going to write a more detailed policy document over the next couple of months. The local facilities have already updated. The ones that we were working with have already updated their policies. Okay, I'm going to wrap it up now. Overall, this project has been terrific for VA, I think. This is a problem we know we've had. It's a problem that everybody has in healthcare, and it puts us, I think, at the forefront on this topic. People are coming to us wanting to know how do they improve hand hygiene, and they know it's a big problem, and we've got some answers to share with people. I just want to make sure that everybody understands what a great job Susan did with this project. I can't imagine anybody who could have done a better job with it. Kim did a good job following up with us and staying with us on this project too. And again, I want to thank Jim Biesecker and Mr. McQuaid for supporting them along the way. And I think there's reason to believe that this project will prevent a lot of bad outcomes that would have otherwise occurred over the next decades, I guess, in the VA and in other hospitals. And that's all I had. Thank you.
Thank you, Noel, and thank you, Susan, for a tremendous project, and thank you, Noel, for your time today. It's special for us to have some great guests with us.